Good morning. This is Dr. John Bennett broadcasting from Miami Beach for Neurosurgical TV. We have the pleasure of having the king of Zoom, Atul Goel. We call him the king because he does a lot of teaching on the internet. And people like Juha bring great people like this to the screen. And I'll turn it over to Juha. Good morning, Juha.
Hello, John. Hello, everybody. Great to see you again. We have the pleasure to have Professor Atul Goel again as our guest. He has been here many times and for very good reasons. He's the chairman of King Edward's Hospital in Mumbai, India, and he's certainly one of the most important neurosurgeons of these times in the world. How to become a good neurosurgeon? I never met a trainee or young neurosurgeon who wanted to be a bad neurosurgeon. So how to become a good neurosurgeon? You need heroes, mentors, and friends. You cannot become alone a neurosurgeon. This is very important. And you have to train hard. Follow the way Professor Atul Goel is doing. This is very important, like a hero or a role model, how to become in your career, in your future life. I have learned very much from Professor Atul Goel. He's an extremely good teacher and good lecturer. Neurosurgery has three parts: operative skills, research, clinical and basic research. Usually we neurosurgeons do and should do clinical research because this is close to our work, and then teaching. Like John Bennett mentioned, Atul is the king of webinars. He's giving a lot of lectures around the world, and he's, as mentioned, he's very passionate and very convincing in his lectures. How do you improve all the time? You should analyze your experience and publish, because this makes you many times better surgeon. At the same time, you should not believe everything. You should find new ways to treat the diseases. Thinking and observing, very important, and you should learn from others to have open mind all of your life. So Professor Atul Goel has numerous publications, more than 800, and 2014 World Neurosurgery selected 69 most important neurosurgeons in the last 100 years in the world. And you see here is Professor Atul Goel, and he certainly deserves this place among the giants. He's doing huge number of cases a year, more than 1,500 cases a year. For that, you have to be excellent neurosurgeon, also organizer, surrounded by a good supporting team, and the patients and society. And of course, you have to have big catchment area, big population in your area to drain all the cases. You should train your best young people. This is very important. My teacher, late Professor Charlie Drake, told that if he cannot find young people who are not in the future getting better than him, then we wait. Then he waits, and some time those people are coming. So this is very important. You should transfer your knowledge and experience to younger ones, because this way you are also growing a lot and doing better in your clinics. So I give the word to Professor Adolf Boyle. He will speak, like mentioned already in the beginning, about Arnold Chiari malformation and its surgical treatment. So thank you very much. Please go ahead, Adolf.
Thank you, Juha. Needless to say that I'm extremely honored and very proud to be on this show. This Juha's webinars have become extremely popular throughout the world, particularly in China. And as Bin Zhu mentioned, that more than 2,500 Chinese neurosurgeons are watching at present this show. It makes me a little bit nervous. And it gives me a great pride. And with humility, I want to present before you, through the courtesy of my dear friend John Bennett. And I see several friends on the screen. Victor is, as usual, smiling to his glory, and Takashi and various other friends. So I'm going to present to you absolutely a revolution in the treatment and understanding of Chiari formation. You see, not malformation. I do not like to call it malformation. Mal means bad or wrong. I am saying it is a formation which is not wrong or bad. It is good and it is divine and it is made by God. Made by God in response to atlantoaxial instability. So that is the concept which I am going to present before you. I have presented this kind of lecture earlier in Juha Symposium and of course on several forums in the world, so I may be repeating. But repeating a very important and crucial subject where there is a possibility of understanding the entire thing in a different manner, different perspective, and to treat it in a different format. So this difference is extremely important for the patient. It is life-changing for the patient. So you please see what I am going to present before you. Craniovertebral junction surgery in 1964. The statement in this article was that it was only an anatomical curiosity and clinical neurology. There was no treatment, no surgery. You can imagine in the next 60 or 70 years, the entire world of craniovertebral junction has changed. It is no longer an anatomical or radiological curiosity, but it is an absolutely a game-changing surgical treatment where you give new life to the patient. And that new life is absolute. So this was my technique, which I described about 35 years ago, where one screw is inserted in C1, once inserted in C2, joint is open and bone graft is introduced in the joint. So this was described several years ago, and I know several neurosurgeons in China are very interested in doing this kind of technique, and I know this technique is very popular in China. And I know of several young and senior neurosurgeons doing this technique. So the title of my presentation is Basilar Invagination, Chiari formation. They are not primary problems. They are not due to embryological issues or birth diseases, they are secondary. Basilar invagination, Syringomyelia, Chiari formation are not primary, but they are secondary to one problem, which is atlantoaxial instability. So you don't have to treat basilar invagination, Syringomyelia, and Chiari formation. You have to treat the father of these problems. These are the children of atlantoaxial instability, and they are natural protective maneuvering. So basilar invagination, Syringomyelia, Chiari formation are not only secondary issues, but all of these three problems are protective against the very big problem of atlantoaxial instability. So atlantoaxial stabilization is the treatment. So that is the basis of my presentation. So this is Chiari or tonsillar herniation. When we talk of herniation, like uncal herniation, tonsillar herniation, subfalcine herniation, there is some kind of emergency in this. But this is no emergency. This is a chronic problem. This is a chronically associated issue. Syringomyelia is not an acute situation. It never happens in acute atlantoaxial instability. Tonsillar herniation does not happen in acute atlantoaxial instability. Like uncal herniation is an acute disease, acute problem. So these are chronic issues related to subtle or small, it is not a very acute instability or very mobile instability. It is a subtle instability, leads to chronic problems, and Chiari malformation or formation and Syringomyelia are long-standing issues. Now I will show you several cases of Chiari formation or malformation. You see, there is no atlantoaxial instability here. The clivus is a little bit flat or platybase here. There is tonsillar herniation and there is Syringomyelia. So the literature says that you must do foramen magnum decompression in such cases or in any other cases. So I am saying that foramen magnum decompression is not the correct operation. You see, this is another case of Chiari malformation. You see there is a little bit small Syringomyelia, and you see the CSF spaces here is much larger than normal. I like to call it external Syringomyelia. So there is a small syrinx here, and there is a large syrinx here. And this is due to chronic changes in the craniovertebral junction. And this is external Syringomyelia. Syringomyelia, you see the odontoid is little bit turned like this. There is Chiari, no foramen magnum decompression. Now, this is a case with basilar invagination, which is very commonly associated with Chiari malformation and with chronic atlantoaxial instability. You see, there is basilar invagination, there is Syringomyelia, there is Syringobulbia. Now you see another thing, there is external Syringobulbia. There is a lot of CSF in front of the cord. The fourth ventricle is large. There is no tight posterior cranial fossa. The subarachnoid spaces in the posterior fossa are large. I like to call this external Syringobulbia. So the posterior fossa is not tight. There is tonsillar herniation, there is Syringomyelia, there is basilar invagination. You see here, there is quite a severe basilar invagination. There is Syringomyelia, there is tonsillar herniation, there is external Syringobulbia, the fourth ventricle is large, there is no tight posterior fossa, there is a lot of CSF in the posterior cranial fossa. When such large posterior cranial fossa, CSF spaces, I like to call it external syringobulbia. Now you see there is syringomyelia here, and there is large CSF spaces here. I like to call it external syringomyelia. So this patient has syringomyelia, and this patient has large CSF in these spaces. This is external syringomyelia. There is large CSF spaces in front of the brainstem and behind the brainstem, external syringobulbia. Now you see this beautiful case. There is huge basilar invagination. There is no tight posterior fossa. Subarachnoid spaces are large. There is tonsillar herniation. There is syringomyelia. And there is external syringobulbia. And there is tonsillar herniation. This is a very unusual case. You see, there is atlantoaxial instability. There is tonsillar herniation. There is CSF space here. This is external syringobulbia. There is no syringomyelia here. So there is a manifest atlantoaxial instability. So manifest atlantoaxial means there is atlantoaxial instability which is radiologically seen. So this is a little bit rare. Now you see in this patient, there is no bone abnormality in the craniovertebral junction, but there is tonsillar herniation, there is syringomyelia, there is external syringomyelia. There is not much external syringobulbia. The literature says that whether there is bone abnormality or no bone abnormality, you have to do, when there is tonsillar herniation, you have to do foramen magnum decompression. And I am saying that foramen magnum decompression is a wrong operation, is absolutely not a good operation. Chiari malformation, syringomyelia, and all the changes in the craniovertebral region, whether there is bone malformation or not, whether there is syringomyelia or not, whether there is syringobulbia or not, whether there is basilar invagination or not, all these problems are related to atlantoaxial instability, and all these are secondary issues. They are children of one father, and that father is atlantoaxial instability, syringomyelia, tonsillar herniation, external syringomyelia, syringobulbia. All are secondary and protective to protect the neural structures from the odontoid process. So this one bone is the problem, and one joint is the problem, and this problem is the issue. So whether there is manifest dislocation, whether there is basilar invagination, whether there is basilar invagination, all these problems are due to one issue, and that issue is atlantoaxial instability. So that is my concept, and that is a huge concept, and that is a revolutionary concept. So if you see the literature, when there is tonsillar herniation, people talk of suboccipital craniotomy, C1 laminectomy. Some people talk of C2 laminectomy. Some people talk of dural opening. Some people talk of dural grafting, tonsillar resection, obex, manipulation of the obex, and so many different types. If you see the literature, there are more than 500 types of operation described for Chiari malformation. Because there are so many described, because this issue is not understood. That is why so many treatments are described. But all the 500 treatments described for Chiari malformation are all not the correct form of treatment. So I described, and many of you know that I described that atlantoaxial instability is the cause of Chiari malformation, and atlantoaxial fixation is the treatment. So this article I discussed in the year 2013. And when I discussed this, there was a very big uproar in the world of neurosurgery. And many of you know that uproar. And there were several letters to editor written to me from various authors in the world that they do not agree that atlantoaxial instability is the cause of Chiari malformation. And I replied to various people in various manners. And if you see, there are several letters to editor from the entire North American neurosurgery and pediatric neurosurgeons. And many of you have heard this controversy. So this was a controversy. And more recently, I produced this article of mine with 388 cases. So this was about 1 year ago. And now my experience is more than 400 cases easily or more. If you read this article carefully, I am showing that 100% of my patients have recovered in their symptoms. So this operation where I have done only fixation without any form of decompression, and you please read this article. And even this article of mine, despite whatever I have said, there was again a letter to editor from a very promising neurosurgeon, very senior neurosurgeon, saying that he does not agree that all these patients should be treated by atlantoaxial fixation. So there has been a controversy. Controversy or no controversy, over the years, there is absolute no hesitation for me to say that a revolution has been introduced in the treatment of Chiari formation, not a malformation. I introduced to you, and I had introduced to the world, a new concept in atlantoaxial instability, where I said that there can be central or axial atlantoaxial instability, wherein there is no compression of the cervicomedullary cord by the odontoid process. There is no dural or neural compression, but still the joint is unstable, and that instability I called central or axial atlantoaxial instability. So there is a world beyond radiology, beyond radiological imaging. So imaging is not showing any instability. There is facet over facet, but the facet is unstable. Like your shoulder joint, many a times there is repeated shoulder dislocation when the facets are in alignment. Similarly, atlantoaxial joint is prone to instability like no other joint in the body. So you see, craniovertebral junction can present with musculoskeletal deformities like this. Now there is no need for decompression in this situation. This is whatever you see is a secondary manifestation of atlantoaxial instability. You treat atlantoaxial joint and you treat this gross deformity. And you give new life, you give new smile, you give new neck, and you make these patients like king. So that is in your hand. You can make these unfortunate people kings. You have to understand this problem. If you do not understand this problem, if you do not treat them properly, you can kill these people and you can completely devastate these people. So you have to treat them properly. Atlantoaxial joint is the most mobile joint of the body. Atlantoaxial joint is the most unstable joint of the body. Atlantoaxial instability is the most under-recognized and most under-treated clinical entity in the subject of spine. Atlantoaxial joint is the most mobile. Occipito-atlantoaxial joint is the most stable. So you see this joint surface is so rugged because there are several ligaments attached. But if you see this facet, there are no ligaments. There are ligaments are not so strong. This is most mobile and most unstable. We have to understand this if we have to treat properly. Lateral, this transverse process is the biggest transverse process. Spinous process, biggest spinous process of C2. Facet of C1 and C2 are the strongest facets of the whole spine. And this we have to use for our treatment. So facets, C1 facet, if you touch the C1 facet, it is stronger than this dense. It is the strongest. C1 facet is the strongest facet of the whole body. C2 pedicle and C2 facet are very strong. So we introduced this technique in the year 1988 or 87. And this is one of the most commonly done technique of fixation in the whole world. And many Chinese neurosurgeons are also very efficient and very expert in doing this treatment. Not many people, I must tell the Chinese people that not many people in the Western world know this technique or can do this technique because this is a difficult technique. And not many people in USA or Germany or they are doing this like in China. I know many people in China are doing this technique. One screw in C1, one screw in C2. So this facet of C1 is the strongest facet. C2 pedicle and facet makes its strongest facet. So the screw insertion is very strong in these two facets. So my technique, and if you have to do my technique, you have to do 3 steps. One is open the joint, introduce bone graft in the facet and remove the articular cartilage, then insert the screw in C1 and C2. Beautiful fixation. So this is the technique, 1 screw in C1, 1 screw in C2, bone graft, bone graft, bone graft in the joint. Spacer, all right, whether spacer or no spacer, but bone graft is a very important. Occipito-cervical, I introduced occipito-cervical fixation in 1987. We were the first one to introduce occipital screws. You can see occipital screws we introduced for the first time in the literature. So occipito-cervical fixation, occipital C1, C2. So this is what we described. But what I am saying today is that occipital bone inclusion in craniovertebral fixation is not necessary. C1, C2 fixation should be done. Occipital bone inclusion is never necessary. So this is one message which I am giving you, that occipital fixation should not be done. Is inclusion of occipital bone necessary or counter-effective? I am saying it is not necessary and it is counter-effective. The best treatment is C1, C2 fixation, even when there is assimilation of atlas. So in the year 1988, so 33 years ago, we described this technique. One screw in C1, one screw in C2, open the joint, do fixation, and you see this is completely like rock fixation. There is no occipital inclusion in the fixation. And over the years, as I mentioned earlier in UR symposium, personal experience is more than 3,000 cases of such fixation, one in C1, C2 fixation over the years. In children, in young children, in infants, you see this is an infant, less than 1 year old, and there is a Syringomyelia. If somebody comes and punches the syringe, I want to do syringe shunt, he will certainly kill the person. Syrinx is a secondary protective maneuver. You see there is external syringobulbia, external syringomyelia, syringomyelia. The treatment that is required is mobile dislocation. You do atlantoaxial fixation. Another infant, less than 1 year, 7 or 8 month old child, you see the bone formation. There is atlantoaxial instability. The facets are beautifully strong. You do atlantoaxial fixation, you give new life to the child. This is another small child. You see this child and you see this deformity, abnormality, very bad abnormality. Just see this beautiful young boy, how he is walking. And now you see how he is walking very soon after surgery. Little bit slower, but normal. You see the deformity, and you see the neck is straight, the body is straight, and absolutely new life to this small little children. So screws were not neurosurgical. Screws were never neurosurgical equipment. They were orthopedic equipment. Facets, neurosurgeons never knew about facets. These were orthopedic in the gamut, in the scope of orthopedic surgeons. So we introduced in the subject of craniovertebral junction, screws and facets and atlantoaxial instability, and introduced a new dimension to the subject of craniovertebral junction. C2 ganglion, I will discuss some things which I have already talked about because they are very relevant to the subject. C2 ganglion covers the joint, so you can cut the C2 ganglion. So I introduced for the first time in the literature, sectioning of the C2 ganglion to expose the C1, C2 joint, which I am saying today, it is not necessary in more than 85 to 90% of C1, C2 fixation, except in complex situations like we get nowadays. I'm getting complex cases from all over the world, and many of these complex cases need such treatment of C2 ganglion resection. But this resection opened a new window, was a revolutionary introduction in the field of craniovertebral junction, C1, C2 fixation by ganglion resection. Of course, we have to know the anatomy of this region very well, bony anatomy, vertebral artery anatomy, anatomy in the patient. Sometimes the vertebral artery can go very deep inside the facet, and if you do not know, you cannot do, you can kill the person. So these medial quadrants are important. I said this in 1988. Introduce your screw up and here, not here, not here, not here, and you will be safe for vertebral artery. So we mentioned about vertebral arteries in transarticular fixation, and this is the most beautiful form of fixation that you have to learn and you have to practice, because there is a potential to give new life to these people. If we learn this technique, we do introduce in our subject of spine or in subject of neurosurgery a new revolution. Now young people or old people cannot say, I don't want to learn and I don't want to do complex cases, because spine and craniovertebral junction and neurosurgery are complex issues. We are doing this because we like to do complex issues. So we have to learn and do this treatment because we can give new life to our patients. And as I mentioned, more than 3,000 times I have ventured into this fixation and I have given new lives to several people. So this is my position, which I described. Whether you use navigation or whether you don't use navigation, I used to do navigation assisted, but I do not use navigation now for several years. This is a freehand technique of introduction of screws. So this is C2 spinous process, where there are lots of muscles attached to the C2 spinous process. We have to cut. So we do fixation, but if we do not cut these muscles, any kind of fixation will be demolished by these muscles. So we have to learn the anatomy of ganglion, anatomy of the artery, anatomy of the bones, anatomy of the artery in the patient. You see, the vertebral artery is not in the normal situation. And we have to do elaborate investigation to learn the anatomy and how to introduce the screw, how to protect the vertebral artery is a new revolution in craniovertebral junction surgery. This is the most beautiful bone in the body with a king, with a crown. This odontoid process is the most dangerous bone in the body. It is the bone which gives, the entire craniovertebral. There is no dangerous bone in the body than this. And it hits the cervicomedullary junction. It does not hit the cervicomedullary junction. This bone, the entire lecture of mine is to protect the human body from this most beautiful, but most beautiful things are most dangerous things, as we have learned to experience in our life. This is the facet of C2. This is the vertebral artery. This is the superior facet. This is the inferior facet. You see, they are away from each other. There is an extra bone here, largest spinous process, largest facet, and this is the bone which is a very important bone for our treatment. I also described C2 spinous process and C2 laminar screws in the year 2004. C2 laminar screws were described for the first time in the literature in this article. And C2 laminar screws can also be used on some occasions. So here, this was in the publication, C2 laminar screws and occipital screws. And as I mentioned to you, I described suboccipital screws, laminar screws, spinous process screws, but I do not use these kind of screws now for several years. We also described intra-articular spacers for the first time in the literature. And of course, these are very popular in China. And I know of several groups using these spacers. And that is why I brought this slide for you. Facet distraction spacers, indications and techniques. I must mention to you, I described this, but I do not use these spacers in several cases these days. Atlantoaxial instability can be of several types. It is not just anteroposterior dislocation, vertical mobile dislocation, vertical. Now you see this slide, there is no dislocation here on flexion of a head, it goes up. There is no atlantodental disturbance, it goes up like this. So this is vertical atlantoaxial instability, and I will discuss that these bone fusions are protective, long time, short neck, Long time muscle spasm results in bone fusions, and these are secondary and protective. Fixed dislocation. Nowadays, this entity is not so commonly discussed, but 25 years ago, 30 years ago, there was an entity called fixed dislocation. And I have no hesitation to say that I completely demolished this entity of fixed dislocation. And I said that it is never fixed, and you can reduce atlantoaxial dislocation by opening the joint and manipulating the facets. So I introduced this concept, which has completely revolutionized craniovertebral junction surgery. You see, in flexion and extension, there is no movement, but you open the joint and you completely realign the craniovertebral junction. So this is fixed dislocation in the previous definition, but it is not fixed. Open the joint and craniovertebral junction realignment. For those who do not know, these kind of patients were treated by transoral decompression. Even many people, particularly in Western world, in entire Europe and entire USA, transoral surgery will be done for this. And many parts of the world will still do posterior decompression for this. There is no need for anterior decompression or posterior decompression. What is required is craniovertebral realignment. When I introduced this technique about 20 years ago or 23 years ago, there were many people who completely, were not very happy with the technique or with me, and I was given very, they were almost fighting with me. But now many people and most people in the world are doing this technique, and you all know it, that this is the treatment. You see, this patient would have been treated by transoral decompression, but no, I introduced this facet realignment. This, you see, it is almost touching. It is almost touching the arch of atlas. And you see there is no decompression from front, no decompression, and there is a realignment of craniovertebral junction. Then there is a dislocation called lateral dislocation, when there is facetal, when the arch of atlas is disrupted, when there is bifid arch of atlas, the facet of atlas goes laterally. So this is lateral dislocation. This is complete disruption following trauma. You see, there is a huge injury and the whole atlas is disrupted. And you will not be surprised, but these kind of patients were treated by decompressions. But you know now that you open the joint, manipulate the facets and realign the facets, and there is no decompression which is required, and there is a revolution in the treatment. Rotatory dislocation. Again, I presented this in my previous UHA symposium. Rotatory dislocation like this in these kind of young people were treated by decompression, which is an absolutely wrong treatment. Learn the art of opening the joint, learn the art of manipulating the facets, learn the art of reducing the dislocation, and you can give new life and new neck to these several children. And fortunately, I'm getting such children from all over the world, and there is such a great pride when I talk to you that I give new life to these kind of children and these kind of patients. You see, there is complete neck is like this. There is no compression, not much compression, but we know that this is an unstable spine. You do fixation, you give this beautiful neck in the immediate post-operative period. You see, this boy lost his hair. You see, there is this hair which were not so wonderful at this point of time, but you see the neck has become quite straight. I will not say this is normal, but this is quite normal. Open the joint, manipulate the facets, do C1, C2 fixation. So you see, this was a little bit unusual case where I manipulated the facet on one side and I reduced this dislocation. You see, odontoid process, I brought it in the midline and I did this fusion on one side. The other thing I want to talk about is, of course, I want to talk of Chiari malformation. I will like to talk of Chiari malformation. But basilar invagination is a brother of Chiari malformation. Basilar invagination is not stepbrother, is first cousin, first brother of basilar invagination. The father is one, the mother is one, and that father and mother is atlantoaxial instability. So in 1998, I divided basilar invagination into two groups. One is with Chiari and one is without Chiari. With Chiari and without Chiari. You see, when there is a direct indentation, atlantoaxial instability is manifest. So at that time, we divided into two groups. And I said at that time in 1988, 23 years ago, that these kind of patients need transoral decompression and these kind of patients need foramen magnum decompression. So I described basilar invagination with Chiari and without Chiari, that when there is Chiari, you need to do foramen magnum decompression, and here you need to do transoral decompression. And we described for the first time in the literature that there is no need to open the dura. In 1998, 23 years ago, that for Chiari, there is no need to open the dura. So this was very big description at that time. There are many people in the world still doing foramen magnum decompression and they do not open the dura. They must know that we described this entity for the first time in the literature. In the year 2004, we described, also you see the beauty. We described this kind when there is no Chiari, odontoid process is going up. We described, and there is Chiari here. In 2004, my own concept was that there is basilar invagination. This type, group A, basilar invagination, can be reduced and they may not be, you may not do any decompression. In 2004, I described on a very big number of cases that they can be, there is no need for decompression. You open the joint, distract the facet, and realign. And this is due to an unstable atlantoaxial joint. Instability is the problem and stabilization is the treatment. But in 2004, we described that such patients need, group B needs decompression of foramen magnum. So this was my own description. So group 1, transoral decompression, transoral surgery, this was my initial description, and group 2, foramen magnum decompression, this was my initial in 1998, but then we described that, then we described that group A needs no need for decompression, you need to do craniovertebral junction realignment. And I will show you several cases where we have done craniovertebral junction realignment. And we know that many people in the world are doing, including many groups in China. Open the joint, distract the facets, and realign the craniovertebral junction. realign the craniovertebral junction. When I say many people in China are doing, many people in India are doing, many people in Bangladesh are doing, many people are doing, but I can still say not a single group in North America is doing this. And it is unfortunate that they still do transoral decompression for such patients. It is absolutely unfortunate because it has not been described in North America or in Western world. They do not wish to do this or follow this. If it was described in North America, they would have certainly did this. But you see now, there is basilar invagination, craniovertebral junction realignment, no decompression from front, no decompression from behind. Basilar invagination, complete craniovertebral junction realignment, atlantoaxial realignment is the treatment. You see this beautiful case. You see how much it is going. Transoral surgery was done. I used to do transoral decompression. My series is a huge series of transoral decompression. But we changed, we modified, we revolutionized completely the whole craniovertebral junction, complete revolution, open the joint, distract the facets, and do atlantoaxial fixation. This is another case. You see how much craniovertebral basilar invagination and complete realignment, and there should be no controversy in anybody's mind. You see, if I have to show several cases, I can go on and on. And you see here, there is Chiari malformation, there is external Syringomyelia, there is external Syringobulbia. They are all secondary problems. There is basilar invagination. So this basilar invagination, fusion of C2-3, Klippel file abnormality, they are all children of one father. This father is a very productive human being. This father is atlantoaxial, the king of joints, and that king of joint is a very productive. All his children, you see, Klippel file is his children, basilar invagination is his child, external Syringomyelia is his child, Chiari is his child. This kind of joint malformation are secondary. And I have to tell you, these children are very faithful to the father. They protect their father. Father is notorious, but children are protective. You have to take care of the notorious father, and that notorious father is atlantoaxial instability. You treat and everything will be all right. You see, there is basilar invagination and there is realignment. So we have got several hundred cases over the years, several hundred. So I will give one message to entire world through your symposium, through your seminar, that don't do decompression. Is a wrong operation. I know I have been given this lecture for last 25 years. Many people still do decompression, and I have to give this message loud and clear. Don't do wrong operation. Don't do decompression in such cases. You see, there is huge basilar invagination, which is the father, atlantoaxial instability. See the Syringomyelia, external Syringobulbia. You take care of the notorious father. All these children are protective. This is another one. You see basilar invagination, external Syringobulbia, external Syringomyelia. There is no tight posterior fossa. Don't do decompression, either from front or from behind. A complete revolution in the treatment has been made. You follow that treatment because it is in the interest of your patients. It is in the interest of science. You see complete craniovertebral junction realignment. This is another basilar invagination. You see there is no space here. Don't do decompression. Learn the art of opening the joint. Learn the art of distraction of the facets. and learn the art of C1, C2 fixation, and you will give new life, an absolutely new life to your patients. That is your learning. If you have a very tough mind, if you have a very impermeable mind, if you don't have a soft mind, you don't want to listen, you don't want to agree, you don't agree. I don't mind whether you agree or you don't agree. You see, this is beautiful images are in front of you. At least your eyes should be normal. Vision should be normal. If your vision is normal, you see how a beautiful reconstruction has been made. This child was my first case I did in the year 2000, 21 years ago. This boy had come on a wheelchair, and within 3 months, his father is holding his hand. You see, there is basilar invagination, and I did complete craniovertebral junction. This was my first case in the year 2000, 21 years ago. You see, there is dislocation here, and there is an unstable facetal instability. You do craniovertebral junction realignment. This is another case, maybe I have shown this earlier. This is another case. You see how you can do craniovertebral junction realignment. There is no place in the world to do any kind of decompression. So that is my message number one to you. You see, there is instability. You do. So what we introduced in the literature is that transoral surgery, foramen magnum decompression surgery is absolutely negative operation. So there was an era of decompression. Then there came an era of decompression and fixation. And now there is an era of craniovertebral junction realignment and only stabilization. I must mention that in China, this era is still very prominent, era of decompression and fixation in China. I know there are many 2,500 Chinese neurosurgeons who are watching this presentation, and my message to Chinese neurosurgeons is that many Chinese neurosurgeons are still in this era of fixation and decompression. I want you to migrate to this era of only fixation and no decompression. So basilar invagination is an issue of instability, and stabilization is the treatment. Transoral surgery is completely historical. And I have no hesitation to say that I completely demolished transoral surgery from the domain of neurosurgery. Now I want to take you to another dimension, to another world, and I want to introduce this family to you. Family of atlantoaxial dislocation, family of atlantoaxial instability, family of this very premonstrous father, and how there are natural reparative games. When there is atlantoaxial instability, there are many nature's reparative games that happen. I already said that atlantoaxial instability is the most mobile joint and the most unstable joint of the body. Atlantoaxial instability has to be learned, has to be understood if you want to treat your patients properly. When there is atlantoaxial instability, there are several musculoskeletal abnormalities, many musculoskeletal, like short neck, torticollis, bone fusions, platybasia. So all these musculoskeletal deformities or musculoskeletal alterations, not anomalies, alterations. You do atlantoaxial fixation, only fixation, no need to do any kind of osteotomy or decompression or anything. The father of all these problems is atlantoaxial joint. You do fixation, the neck can become long, the neck can become straight in the evening of the operation. And you can see this beautiful smile in the evening of operation, not after 1 month or 5 months or 10 months. In the evening, the neck will become long. So these musculoskeletal problems are secondary to atlantoaxial instability. You do atlantoaxial stabilization, all these secondary things will become normal. So these short neck, torticollis, bone fusions are secondary and protective. Now I will show you some cases which I have already shown in your symposium earlier. You see this neck deformity. Although the smile has not come, but the neck has become straight, and I have done no decompression, only fixation and an absolute new life. You see there is a little bit smile here, but the neck is not very straight, but the smile is there and the limbs are there. The neck, hands, and legs become normal. The smile is more pronounced here. You see there is an atlantoaxial instability here. And what is required is only one thing. You treat the father, you treat the origin or the mother of problems. The mother of all problem is one. And that problem is atlantoaxial instability. You stabilize and you give new beautiful smile and beautiful life. You have to say that you want to learn the art of craniovertebral junction stabilization. You want to learn the art of opening the joint. You want to learn the art of C1, C2 fixation. And you have the potential to give this smile and new life to your patients. You see here long neck and straight neck, and you see the unstable atlantoaxial joint. So all these problems are not primary issues, they are secondary issues. So you see there is a simulation of atlas and there is basilar invagination. You do atlantoaxial fixation or never occipital fixation, no occipital fixation and no decompression. So this is one message to Chinese neurosurgeons. Decompression is not necessary. Don't do decompression. I saw some presentations from China. Decompression still comes. Don't need for decompression. Decompression is still discussed. No decompression. You see this kind of deformities can be treated. Of course, the deformity is not returned, but this boy is now happy with his family. This man is happy with his family. And this was his case, basilar invagination. I treated him beautifully and I gave him a fantastic new life. Bone fusions. Bone fusion is another child of the same father and mother of atlantoaxial instability. Bone fusion is a protective response to craniovertebral junction instability, a new concept. So when you see such bone fusions, don't start doing osteotomies. Think about C1, C2. There is external Syringomyelia. You see external Syringomyelia. There is external Syringobulbia. No need to do any decompression here. No need to do any decompression. You see such powerful smile in this young little girl. You see very difficult C1, C2 fixation, but you give new life. You see this another child, she was not able to even breathe properly. And you see she's able to stand with me and the smile in the doctor is as big as the smile in his patient. And this patient has got an absolute new life, no decompression, C1, C2, difficult operation. These bone fusions are secondary. This Syringomyelia is secondary. This Chiari malformation is secondary. If you tell me I want to come and do decompression, it will be a nonsense operation. If you say I will come and do syringostomy, this will be the second unbelievable operation. You do fixation, and you give new smile. This is a revolution in the subject of neurosurgery and spine surgery. Bifid anterior and posterior arch are not primary phenomena. I mentioned previously, the facets go lateral. There is a lateral dislocation. Atlantoaxial instability is the issue. You do fixation, and this bifid opens and closes when you do flexion, bifid opens. You do extension, bifid closes. So this I have discussed with you. And bifid, when you see bifid, it is a clear indicator of atlantoaxial instability. You do stabilization, and there is no possibility. You see this beautiful child with bifid, and I hope I am having the video of this. I gave him new life. I gave this boy a new life, and I gave the family a new life. Nothing, no decompression, there is a tonsillar herniation, there is Syringomyelia. If you say I will do decompression of foramen magnum, I will not, I will not be too happy about it. This patient has already open foramen magnum, open C1. This is a nature's decompression, and this is a dynamic decompression. And this child, you see the father, how he is jumping. You see the boy, how he is walking, and a new beautiful life for your patients. You have bone fusions. Bifid are natural protective maneuvering, and they indicate to you the presence of atlantoaxial instability, and they indicate to you the presence of an unstable joint. Os odontoideum is also an indicator of an unstable atlantoaxial joint. When there is os odontoideum, it is a diagnostic of atlantoaxial instability. I must tell you that several people in the world are still doing transoral decompression and foramen magnum decompression and occipitocervical fixation. It is a wrong operation. Atlantoaxial fixation is the treatment. Retro-odontoid pseudotumor is also an indicator of an unstable joint, a protective phenomena. You see this small little cushion like Chiari comes behind. This small little cushion comes in front. You see there is a hole in the bone. When you do flexion, this thing goes inside the bone. This is a reservoir, and this is a protective reservoir in the presence of os odontoideum. This is a beautiful, you have to understand this. If you don't understand, you try to read my articles. If you don't want to read my articles, I have a feeling that I will not be able to at least listen to what I'm saying. You see, there is this kind of cyst here. This is a protective cyst. There is os odontoideum. This is a self-destruction of the bone. Self-destruction. You see, there is a cyst here, and this cyst goes after fixation. And os odontoideum, you see, there is a hole in the bone, there is a mobile cyst, and there is a complete reduction and fixation. You see, there is a mobile cyst, and this cyst is gone. So this cyst is an indicator of atlantoaxial instability and an indicator for the need for atlantoaxial stabilization. So there are many patients like this. You see the hole in the bone, and this cyst is a mobile, this retro-odontoid pseudotumor we introduced for the first time in the literature, that they are indicate in a Japanese journal. And if Takashi is listening to my lecture, Takashi, this was introduced first time, that retro-odontoid tissue is an indicator of atlantoaxial instability, even when there is no atlantodental interval disturbance, even when there is no facetal malalignment, in a Japanese journal about 25 years ago. You see there is a cyst here, and this cyst is a little bit reduced in the immediate post-operative period, indicates the need for stabilization. Syringomyelia is another child of atlantoaxial instability. No child is, father may be a little bit dangerous or a little bit productive, but Syringomyelia is a child. It is helpful, it is protective, it is never harmful. So I have to say that we completely revolutionized the treatment. Otherwise, syringo-subarachnoid shunt, syringoperitoneal shunt, syringopleural shunts, hundreds of shunts were described for Syringomyelia. Syringomyelia is always secondary. There can be tumor and syrinx. There can be kyphosis and syrinx. There can be tumor and syrinx. Don't do anything to the syrinx. Remove the primary problem. Primary treatment is necessary. Syrinx manipulation is not necessary. It can be harmful. So dura can be stretched. Dural opening is not necessary. As I mentioned, we were the first one to say that do not open the dura. Arachnoidal sectioning, tonsillar resection, we said that do not do all these kind of things. When there is tumor and chiari, remove the tumor. When there is tumor, trigeminal neurinoma and chiari malformation, remove the tumor, the chiari will disappear. You see, we published this long time ago. Treat the primary problem. When there is tethered cord and chiari, treat the tethered cord, not the chiari. When there is a bad tethered cord and hydrocephalus, you treat the number one problem. Number one is the tethered cord. Number two is hydrocephalus and other thing. Chiari is the third thing. You treat the primary, everything. This is the father. These are the children. Don't treat the children, treat the father. There is a encephalocele here, treat, and there is chiari. Treat the encephalocele, not the, there is arachnoid cyst and chiari. There is arachnoid cyst and chiari. You treat the arachnoid cyst. Don't, hydrocephalus is secondary. Tonsil herniation is secondary. This is the primary problem. Hydrocephalus and chiari and syrinx. So when there is hydrocephalus, there is a little bit controversy. I don't want to touch on this at present. So I showed you this slide when there is syringomyelia and dislocation. Do not touch the syrinx, you treat the dislocation. This is a child with Down syndrome with quite a complex. When there is craniosynostosis, there can be chiari. But this is not craniostenosis. When there is craniosynostosis, you treat craniosynostosis. When there is chiari and atlantoaxial instability, do not do decompression. If you do decompression, you can clearly harm this child. There is secondary syringomyelia, external syringomyelia, external syringobulbia, and so many other issues. So there is chiari malformation, there is atlantoaxial instability. There is a unilateral, you see, there is a unilateral tonsillar herniation. There was a torticollis in this child, and there is unilateral, so unilateral tonsillar herniation. In short, we introduce a new format of understanding, absolutely revolutionary concept that there can be central or axial instability when there is no compression by the odontoid, no facetal malalignment. So this is what, so we introduce a new clinical entity called central or axial atlantoaxial instability. We had talked about such lumbosacral listhesis, C1, C2 listhesis as a cause of basilar invagination. This was my article about 20 years ago or 25 years ago, when we talked of group A basilar invagination. You see, there is listhesis. You treat listhesis by fixation. You treat C1, C2 by fixation. Now you see there is chiari malformation, syringomyelia. There is listhesis of C1 over C2. You see this listhesis? You treat the listhesis by facetal distraction and you have a craniovertebral junction realignment. There is no need to do decompression from behind. There is no need to do decompression. This was my article 23 or 24 years ago. You see, there is basilar invagination. There is basilar invagination. There is listhesis of C1 over C2. You open the joint, do the fixation. There is craniovertebral junction realignment. This is another case. There is listhesis. You do craniovertebral junction realignment. There is chiari malformation. There is syringomyelia. Do not do any kind of decompression. That is my message. So as we advanced about 10 years or 12 years ago, I introduced this classification. a new classification on the basis of facetal realignment. You see the type 1. Type 1 is when the facet of atlas is in front of facet of axis. And there is atlantodental interval disturbance. That is listhesis, you treat the listhesis. Now you see this beautiful new. There is basilar invagination type 2. There is no atlantodental interval disturbance. We had described that we should do foramen magnum decompression. In this, the whole world still does foramen magnum decompression. But we described that the facets can be malaligned. Facet of C1 can be behind facet of C2. Here C1, it is in front. So this is an unstable joint. You have to do atlantoaxial fixation. So this is type 2. Type 3 is even when the facets are in alignment, even when there is no atlantodental interval disturbance like this, but Chiari is here, Chiari is here, Syrinx is here, Syrinx is here. Presence of Syrinx and presence of Chiari are indicators of type 3 atlantoaxial instability. You do atlantoaxial stabilization, you see the Syrinx is gone here. So my concept is absolutely clear and absolutely revolutionary. You do whenever there is Chiari or whenever there is Syrinx or whenever there is basilar, whenever there is all the children of father, of all kinds of children. Basilar invagination is one child, Syringomyelia is another child, bifid is another child, os-odontoidium is another child, bone fusions is another child, assimilation of is atlas child is, C2-3 fusion is another child, platybasia is another child. When any of these children is present, it indicates that the father is creating a problem and you need to do atlantoaxial stabilization. You see there is unstable, difficult operation. You see the basilar platybasia, you have the courage, you have the power, you have the strength to do fixation. If you can do, you give new life. If you say, I want to do occipital fixation, okay, you might be okay. But if you do C1 direct fixation, that is the best. In such cases, you might just get away with occipital fixation. But I do not recommend occipital fixation. You see, there is C1 assimilation. You might get away with occipital fixation, but I have told you for last 17 or 18 years, I have never done occipital fixation. Always C1, C2 direct fixation. There is tonsillar herniation. You see there is external syringobulbia. There is syringomyelia. These are all children of atlantoaxial instability and they need stabilization. Now I will show you several cases. You see there is unstable, you do stabilization. There is no need to decompress, no need to touch the syrinx, no need to touch the bone, no need to touch the dura. This is basilar invagination. You see very abnormal facets. If you have the anatomy, if you have the technique, if you have the skill, they are difficult operation like no other operation in the entire gamut of neurosurgery or orthopedic surgery or spine surgery. If you can have the guts, if you have the talent to expose the C1 in this case, you see the syrinx is gone. You see the huge syrinx is gone. The tonsil has gone up. You see there is no tight posterior fossa. If you do decompression, it is a wrong operation. You do C1, C2 fixation. You see how the syrinx has gone and how the beautiful the patient will improve. You see there is Chiari formation. There is external syringobulbia. There is external syringomyelia. There is syringomyelia. There is no atlantodental interval disturbance. There is no facetal malalignment, and there is no atlantodental, or you see there is a fixation, and this patient will get a brand new life. Now you see this beautiful patient, beautiful. You see there is C2-3 fusion. There is external syringomyelia, external syringobulbia, fourth ventricle is large, posterior fossa there is not tight, there is Chiari. If you do posterior fossa decompression is an absolutely wrong operation. you do C1, C2 fixation, you have in your hands, you have the power in your hands to give a new life. This is another case of Chiari with Syringomyelia. There is no atlantodental interval, there is no facetal malalignment, there is C1, C2 fixation. So all kinds of basilar invagination, the instability is the cause, whether it is type 1A, type A, or type B. And I have got several hundred cases where I have done fixation as the treatment. So basilar invagination, Syringomyelia, Chiari formation are all children of atlantoaxial instability. There is no decompression required in basilar invagination. Instability is the problem and stabilization is the treatment. Now I go to Chiari and carefully see. You know about the various forms of treatment of Chiari. I am saying atlantoaxial stabilization is the treatment. And I am now saying on the basis of more than 400 cases, this is Chiari, this is external Syringomyelia, this is external Syringobulbia, C1, C2, there is no decompression, there is no decompression. You see here, there is Syringomyelia, there is Chiari, there is facetal malalignment, there is no atlantodental interval disturbance. Syringomyelia has marginally reduced in the immediate post-op. This is immediate post-op. I am now saying one more thing to you. Whether the Syringomyelia reduces or not is not the issue. Whether the tonsil will go up or not is not the issue. The patient will clinically get a new life in the immediate post-operative period. That is the bottom line. You see, there is tonsillar herniation, there is Syringomyelia. Syringomyelia has reduced in the immediate post-operative period. Now I will give you another beautiful statement. Syringomyelia will reduce in 100% of patients if you do a scan after 1 year. Syringomyelia will reduce in 20% of patients in the immediate post-operative period if you do a scan MRI after 1 week. Syringomyelia will reduce in 50% of patients if you do an MRI after 1 month. Syringomyelia will reduce 100% if you do after 1 year. And I will show you several cases now. You carefully see no atlantodental interval, mild facetal malalignment, tonsillar herniation, Syringomyelia. I am doing only atlantoaxial fixation. You see the Syringomyelia reduced remarkably after 1 year of surgery. And I have to say that your patient, my patient, has got a new life. Tonsillar herniation, no facetal malalignment, no atlantodental interval. This is immediate post-operative. I will show you. There is Syringomyelia, there is tonsillar herniation, no atlantodental interval. There is a lot of basilar invagination, assimilation of atlas, no atlantodental interval. You see the Syringomyelia has reduced. There is no decompression. This is Syringomyelia, tonsillar herniation, no atlantodental interval disturbance, no facetal malalignment. I have done only fixation. This is Syringomyelia, tonsillar herniation. If you carefully see, there is external Syringobulbia. There is no tight posterior fossa. There is no atlantodental interval disturbance. There is assimilation of atlas. I do fixation and you see atlantoaxial fixation, Syringomyelia reduced. There is no decompression after 1 year of surgery. Like an airbag of a car, I am saying that tonsil Chiari is a formation and not malformation. Its presence is diagnostic of atlantoaxial dislocation. Now this case, I have already shown you, I think, there is Chiari, Syrinx, atlantoaxial instability, Syringomyelia reduced, tonsil goes up, there is no bone decompression or any kind of decompression. You see syringomyelia, tonsillar herniation, no facetal malalignment, only fixation. I have used a spacer, but I don't use spacers all the time. No facetal malalignment, no atlantodental interval, no tight posterior fossa, external syringomyelia, external syringobulbia, and no decompression, only fixation. Syrinx will reduce 100% of times if you do a scan after 1 year. You see, and after 6 months, 100% of time it will reduce. You see, there is syringomyelia, tonsil has gone up, and the syringomyelia has reduced. There is no decompression. There is another case. You see, there is no atlantodental interval, mild facetal malalignment, only C1, C2 fixation, and the syrinx has reduced remarkably in size. There is syringomyelia, there is tonsillar, there is basilar invagination, no decompression. You see the syringomyelia has reduced. I have no hesitation to say that the whole world will do posterior fossa decompression, durotomy, tonsillectomy, obex removal, syrinx shunt. All those operations are negative operations. You do this, you see there's beautiful possibility of giving new life. You see there is another similar case like I have shown you. The syrinx has reduced and there is only atlantoaxial fixation. This is syringomyelia and basilar invagination. I will show you several cases without basilar invagination very soon. There is no tight posterior fossa, there is no decompression, and there is syrinx has reduced and your patient has got. I have got 100% patients getting new life after surgery. This is syringomyelia has reduced after surgery. There is no tight posterior fossa. There is external syringobulbia, external syringomyelia, external syringomyelia. Now you remember this entity, external syringomyelia, revolutionary entity, external syringobulbia, and you see this fixation. There is syringomyelia with basilar invagination. Similar case I have shown you earlier, and you see the syrinx has reduced only C1, C2 fixation. This type of case I have already shown you. You see there is tonsillar herniation, there is facetal malalignment. I do only fixation. You see the tonsil has gone up. You see external syringomyelia, external syringobulbia, tonsillar herniation, children of one father. There is syringomyelia and the syringomyelia has reduced. There is tonsillar herniation. There is no decompression of any kind. You see there is syringomyelia, tonsillar herniation. There is not much basilar invagination. There is facetal malalignment. You do C1, C2 fixation, and there is reduction of syrinx. This is another similar case. Now everything looks similar. Syringomyelia, tonsillar herniation, facetal abnormality, only fixation, and you see there is reduction in the syrinx in the immediate post-operative period. This is very gross abnormality, and there is reduction in the syringomyelia. This is another case of syringomyelia. This is post-operative reduction of syrinx. There is syringomyelia, external syringomyelia, no atlantodental, no foramen magnum decompression. You see the tonsil has reduced and there is atlantoaxial fixation. This case, this syringomyelia, this I have already shown you. I'm sorry for that. This is another case. There is syringomyelia. Syringomyelia has reduced. Facets are in alignment, only fixation. This is syringomyelia, tonsillar herniation, atlantoaxial facetal malalignment. You see the syringomyelia has reduced. There is no decompression. There is no bone. There is no basilar invagination here. So don't say that only basilar invagination is there, so you do decompression or fixation or no. When there is syringomyelia, basilar invagination or no basilar invagination, they're all indicators. You see this syringomyelia, and I have done fixation. The Syringomyelia has reduced in dimension. This is another case. Syringomyelia has reduced and only fixation is done. You please see this very carefully. There is no basilar invagination. There is tonsillar herniation. There is mild Syringomyelia. And I have done only fixation. You see the Syringomyelia with basilar invagination, with assimilation of atlas. I do C1, C2 fixation. The Syringomyelia has reduced. You see, most important is the patient. And I am telling you, all patients have got a new life. You see Syringomyelia reduced, only fixation. I will show you, of course, videos. So as I mentioned to you, there were many people saying, I don't agree, I don't believe, I don't think, I don't like, I don't, this is wrong, that is wrong. Your thing works only with basilar invagination. No, I am saying whether there is bone abnormality or not. Suboccipital pain is an indicator of an unstable spine. So you will see that all these patients have suboccipital pain. All these patients can have voice disturbance. All these patients can have breathing disturbance. Now you see this title of this, Atlantoaxial fixation for treatment of Chiari and Syrinx, where there is no bone abnormality. No bone abnormality. So I published this article. So there is no basilar invagination in this case. There is Chiari and there is Syrinx, but there is atlantoaxial facetal malalignment. Now there is no real bone abnormality here, and there is a facetal malalignment and Syringomyelia. I do fixation, no decompression, and you see Syringomyelia has reduced. There is Syringomyelia here. There is no bone abnormality, no need to do decompression. You see there is some facetal malalignment. The Syringomyelia has reduced. There is big Syringomyelia. It has reduced. I am saying without hesitation, there is no need to do decompression. There is only one thing, only one difficult thing. Learn the art of doing C1, C2 fixation and remove this fascination for the term decompression. Decompression is not a scientific term. There is no decompression required. You see Syringomyelia, there is no problem here, some facetal malalignment. Syringomyelia has remarkably reduced and there is fixation. There is Syringomyelia, no problem, and I have done fixation. This Syringomyelia, no problem, some problem, and you see reduction. This is another case, huge Syringomyelia, tonsillar herniations, facetal malalignment, no problem, and there is Syrinx reduction. There are some repetitions which are coming, so please ignore these repetitions. There is Syringomyelia, and the Syringomyelia is gone. There is no facetal malalignment. You see Syringomyelia, and the Syringomyelia has reduced. There is Syringomyelia. There is no bone abnormality, no facetal malalignment. You see the Syringomyelia has reduced. There is C1, C2 fixation. And this is the patient in the immediate post-operative period. And you see how he's walking and how he's walking now. This is in the immediate, like within few days of surgery. His gait has certainly become more stable. And then after a few days, he will become a normal human being. Short neck, short head, short spine, short body height are also the children of the same father. When you see short head, short neck, you see this is short neck, short head, short spine. So the whole body becomes short. So to deal with one thing, one atlantoaxial instability, the whole body changes. You see the external syringomyelia is a new term. External syringobulbia is a new term. You see in these 4 cases, there is basilar invagination, there is external syringobulbia. There is, in this case, there is syringomyelia, there is external syringomyelia, there is syringobulbia, external syringobulbia, and syringobulbia. In this case, there is syringomyelia and little bit tonsillar herniation and external syringomyelia. In this case, there is syringomyelia and external syringomyelia. You see, normally you don't get so much CSF. There can be syringomyelia with long-standing foramen magnum tumors. You see, there is a tumor and there is external syringomyelia. So much CSF outside the cause. There is external syringobulbia. So these are all natural protective maneuver. There can be 6 nerve weakness. You see, there is tonsillar herniation, and I did C1, C2 fixation. You see the eye movements have returned to normal. There was 6 nerve weakness here. So 6 nerve weakness can be due to Chiari malformation. You must, you try to, so when there is failed foramen magnum, see many patients I'm getting from all over the world where foramen magnum decompression has been done. And they will certainly not improve. No foramen magnum decompression can ever improve. So I have got a very big series now when there is foramen magnum decompression done, and there is syringomyelia, Chiari malformation, and then I do fixation. You see the syringomyelia reduced in size. This is another case where this patient has been operated 12 times and several types of operations, syringostomy, foramen magnum decompression, ventriculopleural shunt, ventriculoarterial shunt, hundreds of operations done. And then I do C1, C2 fixation. I give new life to this patient. This is another patient. You can see the syringostomy tube here. And this patient is also operated several foramen magnum decompression. I did C1, C2 fixation. You see the syrinx has reduced in size, and this patient I give a new life. This is the patient. He was a very educated man, and he was doing, he was an engineering student. And when I discharged him from the operation theater, you see there was a Riles tube here. There was a urinary catheter. You see how he beautifully he's moving his hands, and I give him new life. You can give new life. Don't keep your mind blocked. Keep your mind subtle. I don't like, I don't believe, I don't this thing. So you can come to, my center, and I will show you many people from all over the world. Even many from China have visited me, and they have seen this magic. You see, there is Syringomyelia. Many people did foramen magnum decompression. 4 groups did foramen magnum decompression, and everything failed. Then I did, and you see the Syringomyelia has reduced in size, and this patient has got a new, beautiful life. You see, this patient also operated several times. So when there is failed foramen magnum, you see this patient also operated by foramen magnum decompression and Syringomyelia. So there is a weapon in your hand. There is an armory. There is a trick in your hand. You can give a new life by learning this technique of C1, C2 fixation. When I described this, many people in North America said, oh, this does not work in children. Children is not good. You don't do, in India maybe okay. In America, our children patients are different. You have more basilar invagination. We don't get this. Then I produced my series in children. And there are several children in my series where I did C1, C2 fixation. You see the Syringomyelia reduced. This is another child. You see how he was walking before operation and how he's walking, running, and you see the smile on the mother's face. I gave a new life to this child. And if I had done foramen magnum decompression, I would have destroyed this child. You see another, if I had done foramen magnum decompression, no foramen magnum decompression. This is another child with, of course, basilar invagination. And you see the Syringomyelia. The Syringomyelia has quite dramatically reduced. This is another patient with very complex, and the syringomyelia has been reduced. This is another child, and this is another lady now. You see how this lady was having the problem of difficulty and how this smile. You see, you go by this smile, and I can tell you, I cannot tell you more. Many people in the audience are young. Many people I know, Chinese audience, are young people. Listen to me. Chiari malformation, decompression should not come in the treatment. You see this Chiari, don't do decompression, do fixation. This is another, this is the same boy which I am showing you. He had very difficult, you see, he was a very notorious young man. And you see the smile, you see the beauty, and you enjoy. Don't start criticizing me. Oh, no, I don't like, I don't believe, I don't. You just see the smile and say, yes, we like. So C2-3 fusion, C3 compression are not primary. They are issues related to the father, and father is the problem, and father treatment is the, you see there is C2-3 fusion. There is compression here, but this is secondary. Problem is C1-2. You treat the father and everything else will be treated. Idiopathic syrinx, nobody knows the treatment. Syringlo-pleural shunt, this shunt, that shunt. No, C1, C2 fixation is the treatment, and you have the, you can give new life. Spinal kyphosis. Now my concept is spinal kyphosis. This kind of kyphoscoliosis, you should never treat the kyphoscoliosis. There is syrinx and there is Chiari. Whether there is Chiari or whether there is syrinx, this is the child of the same father. This is a stepchild. This child should not be treated. This is also protective. You treat the C1, C2, and this, you see this, the kyphoscoliosis will go. So kyphoscoliosis should never be treated by multiple screws and all. Always there is central instability, whether there is Chiari or no Chiari, whether there is syrinx or no Chiari. There is, this treatment is always C1, C2. So you can have motor evoked potential recovery during the operation. You do C1, C2 fixation, motor evoked potentials can recover during the operation. You see syrinx, you say, and you do fixation when you do tightening this, the motor evoked potentials. So whether there is bone abnormality or not, whether there is basilar invagination or not, central or axial, this is an absolute in treatment. You have to just understand. You see, there is bifid and no compression, but there is external syringomyelia. There is syringomyelia. All these relate to the father and mother of problem, and that is central atlantoaxial dislocation. Hirayama disease is due to atlantoaxial dislocation. This disease described by Japan, but I say you have to read my article. Chiari formation and syringomyelia can be associated with Hirayama disease. So the problem is central instability. Hirayama disease is due to atlantoaxial instability. You have to treat atlantoaxial stabilization, and you can give new life to these children. So my last slide is, can foramen magnum decompression become historical? I say yes. Can transoral surgery become historical? I say absolutely. Don't remain dogmatic. Don't say that this is India, this is China, this is America, this is Germany, this is that. Chiari is a disease in human beings. Tonsillar herniation is a human problem. Syringomyelia is a human problem. You treat that human by identifying the cause, and the cause is atlantoaxial instability. Thank you very much, my dear friends. I hope I have given you some beautiful message. I hope you will have enjoyed my presentation, and you will have the will to treat your patients in a different format. Thank you very much.
Thank you, Atul. Thank you very much for extremely convincing lecture. You made me certainly regret many of my, what you call, historical treatments. I was in the 80s by Crockhart and learned transferal surgery. Of course, the cases are not so many in Finland, small country, but I did them, and also posterior decompression, like you mentioned, so many. So I think your lecture and your concept is very convincing, and I think all the world will follow you. Just wait that also the Western countries are joining this treatment. So this is certainly the best treatment, treating the father.
No, thank you very much for giving me this opportunity. I know there are several people watching this. I know there are several people in China watching this. I know your symposiums are very popular throughout the world. And you have given me an opportunity to give this message to all the young people and the senior people that a revolution is possible. And please don't keep your mind supple, keep your mind plastic, accept ideas. Don't think that I am quite convinced that one small little idea is bigger than 1,000 people operating for 1,000 years. Ideas make the change. You think about this, you think about the possibilities, and you think about the revolution.
Okay, thank you. So I looked at the chat. So most comments were excellent lecture and many thanks for you. But then you have some questions in the audience?
Yeah. Can I ask Professor some questions to my dear friend Atul? What a wonderful lecture. It was like, poetry in motion. And you stressed the point multiple times that the problem is instability. Even though the instability may not be overt, there is occult instability as the pathogenesis of Chiari malformation. And you told about central dislocation, which may not be radiologically visible. And you stressed the point multiple number of times. And also you told that suboccipital headache is a manifestation of unstable joint. That also is a very good point. My couple of questions, maybe you useless questions, but is cough headache a symptom of instability? Because we all teach students that cough headache for Chiari. Is it a symptom of instability? My first question.
Yes. Let me answer this question first.
Yeah.
First thing is, I want, there are many people watching. I want people to respond. And if they say yes, if they think that I am saying something correct, they should mention yes on the chat box. And if they don't agree, they are free to say no on the chat box. I want to see the response as to how many people say yes and how many people say no. So before you say no, you must remember that you should try to think. You just don't say no like that. I want you to think before you say no, but you are free to say no. So I want to see how many people say yes in the chat box. Now, Suresh, of course, you have asked me a very beautiful question, and I wrote one paper on this subject. You will not believe, but I wrote one paper on this subject, why there is pain when you cough in Chiari. You know what? You please look at me. You are able to see me? You please look at me. When you cough, you do like this. There is an acute flexion. You see, when you do cough, there is an acute flexion, and you have an unstable spine. So I have written an article on this. When you cough, the nature protects you by giving you a sudden pain and avoiding that sudden flexion. So my answer to that question is cough is a protective response. Cough is a protective response. It protects you to avoid acute flexion and sudden flexion. So that is the answer to your question. And that is not indicator of high intracranial pressure and increase in tonsillar herniation. That is an explanation. But my answer is that coughing is a natural protection to avoid acute and sudden flexion. Okay, Suresh, next question.
No, second question is, you told about joint fixation as the key treatment for Chiari malformation. But in the event of abnormal vertebral artery course, where you cannot do joint fixation, is just a posterior fixation as good as joint fixation? That is my second question.
See, posterior fixation may be good. Posterior fixation is better than not fixation. But you know what? The best fixation is C1, C2 fixation. I am not saying then vertebral artery, sometimes the joint facet is so high that you cannot get it. So you cannot say, I don't get the facet, so I will not do any fixation. At that time, you can resort to occipital fixation. But that is not the best. Occipital fixation is not the best. If you can put C1 screw, C2 screw, open the joint, introduce bone graft in the joint, it is the best. But if you are not able to do because the vertebral artery is the problem or venous bleeding is the problem or C1 is too, you are not able to expose it because it's too high, then of course you do the second string operation. Second string operation is occipital fixation. Second string operation is C2, 3 fixation. Second string operation is laminar screw fixation, which I described. I described second screw fixation is spinous process fixation when vertebral artery, you cannot put screw because of the vertebral artery. Those operations are your backup, but they are not never primary. But they are also strong enough, but they are not the best. Best is C1, C2. But if you're not able to do C1, C2 screw insertion, then you have to go on your backups. And there are many backups. I have described many backups as you have heard me in my previous presentation. I have described use of C2 inferior facet. I have described transcranial insertion of the screw. I have described various backups. I have described mobilization of the vertebral artery to do my screw fixation. But sometimes it is not possible. So you do alternative fixations, but they are not the best. They are suboptimal, but they are an alternative. Most important is you have to do fixation. There is no alternative. You cannot say, I have come decompressed, I have removed the bone, I have come out. So if there is no possibility of fixation, even if you put bone graft there, that is a suboptimal, but there is a possibility. But the negative is just decompress and come out. That is a negative treatment.
My last question, it may be the most foolish of questions. It is not to offend you, but you told about external Syringomyelia, external Syringobulbia. And so I thought, the definition of Syrinx is a fluid-filled cavity lined by glia. You call Syringomyelia. If it is lined by ependymo, you call hydromyelia. Like that, you are telling the outside subarachnoid space is widened. You call it a cavity or you call it a dilated subarachnoid space. I don't know the terminology.
So this is a very, very beautiful question. And I have been, when I wrote this article, there were many people who wrote to me that this terminology, what you said, that Syringomyelia is a cavitation. So I thought of various other terminologies to hydro, subdural space, and I thought of various terminologies, but then I landed with this terminology, external Syringomyelia, because this Syrinx means fluid, it is external, and it is external to mylia means cord. So I introduced this term, and I have now used this term very, in several of my articles. I have used the term external syringobulbia in several of my articles. So this is a term which may not just be correct, but it indicates the essence
purpose
of what the purpose of my, yeah.
Yeah, what wonderful lecture. Congratulations to you again. Many people may be wanting to ask you questions, and thank you very much, my dear brother.
Thank you, Suresh. Thank you.
We have a question from Radab. Radab, you want to ask a question? You have no camera, but you have audio, right?
Yes, Dr. John, thank you so much. Thank you, Professor Yuha and Professor Atul. As always, you're very impressive in your shared experience. So just to make it brief, Professor, well, my question is, what is your preferred technique in the C1, C2 fixation? Is it that rigid fixation or wiring? And in the rigid fixation, is it trans-articular facets or the polyaxial screws?
Have you said yes to my answer, or have you said no, or have you written yes, or you have not written anything? Tell me first, answer this question.
The honor system.
Have you said yes? If you have said yes, because I see no no's, so you have either said yes or you have not answered. You tell me, have you said yes or no?
Yes, definitely yes.
And if you have not written, I want you to write yes now. Okay? Now you write yes. Have you written? I can see one yes, maybe.
Okay.
So I like to do my own technique, which I described. I described this direct C1 screw, C2 screw. I described this technique when I was 26-year-old man. In the year 1987, 1988, we did our first case, and this technique is now a very popular technique in the whole world. I will say the question, to answer the question of even Suresh, that why not do C1, C2 wiring? You see, if you cannot do direct C1, C2 screw, then you have to do wiring. That is a suboptimal, but there is an option. You see, best is direct C1, C2 screws, open the joint, introduce bone graft, then do C1, C2 fixation. That is the best. But if you are not able to do, then you do other transarticular is also, I have described a double insurance fixation where I do C1 screw and do transarticular fixation. So there are various techniques which are possible, but you have to do the best technique in your hand, in your training. So you should never say that I do not want to learn. You should never say that I do not want to listen. You should never say I will not be open to ideas. You should always say I agree or I do not agree, but I will try to think about it. I will try to think more about it. You cannot say no, 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 no. If somebody had written no, I am sure I would not have liked it, but I am very happy that not one person has written no. So that is my happiness. So any other comment?
Yes, I believe Yannick, you had a question. Do you want to ask that question, Yannick?
I see Abdul Rahman, also my student from Turkey on the screen. Abdul Rahim is my student from Turkey. I know and I will show you Abdul. Abdul presented me.
Yes, sir.
On the screen. He presented me this. Can you see this?
All right.
Yes, I see.
There it is. The seal.
He presented me C1, C2 as a gift he made for me.
That's the royal seal. The royal seal.
Yeah. So Abdul, you want to make any comment for me?
Hi, sir. Thank you very much. It's very nice to listen to you. Great presentation, as always. Thank you.
Thank you.
Can I have a question?
Sure.
Please ask. Please go ahead.
Yes, sir. If the patient has basilar invagination and scoliosis, Should
Yes.
we do C1 and C2 stabilization first or fix scoliosis?
I have told you, Abdul, you didn't listen my lecture properly, okay? I have
Yes.
told you scoliosis,
Yes.
kyphoscoliosis, dorsal kyphoscoliosis should never be treated. It is always due to the father sitting at the C1, C2, whether you have Chiari or no Chiari, whether you have Syrinx or no Syrinx. So this is a revolution.
Yes.
I will say 95% of kyphoscoliosis treated in the world are wrongly treated because they are not treating the C1, C2. You remember this, and you will get more and more cases. My series is now becoming bigger and bigger, where I have treated kyphoscoliosis with only C1, C2 fixation.
Okay. Thank you.
Thank you, Dr.
No,
Goel.
Thank you, sir.
yes.
Yeah, the next. I'd like to ask.
Takashi wants to ask any question. I see Harshad Parekh.
I have
Yeah.
a comment. Thank you, Dr. Gore, the great lectures. I posted in the chat your paper, Neurological Medical Chirurgy in Tokyo. That will be 2005,
Yeah.
craniovertebral junction and basilar invagination and Syringomyelia. Many Japanese doctors are reading your papers in Japan Neurosurgical Society. You have too many papers. So once I examined Dr. Goel, so many papers are listed. But I posted in the chat the Neurological 2005 paper is in your lecture.
Thank you.
Maybe
Thank
so.
you.
Yeah. So everyone can use as a reference. I will look for and read and study. And thank you for a great lecture.
Thank you. Thank you. Victor, you want to say something? Victor?
Oh, yes, Professor Atul. It was a really amazing lecture. So I want to congratulate you about this conference. So most of us, brain surgeons around the world do oral transoral approach to treat basilar invagination. So your method is really revolutionary. So it was an amazing lecture, of course. Thank you so much for giving us the opportunity to listen to you, and also Dr. Yuha for these very important lectures every Friday, every week. And I agree with Dr. John Bennett. You are the king of Zoom.
Thank you. Thank you. Thank you, Victor. Harshad Parekh is there.
Okay.
Maybe you want to say something? You are?
I think very few people, very few neurosurgeons can change the world. I think you have done with your revolutionary ideas. This will be the future, and this is really something very special. So, like I told in the introduction, you should not believe everything what is done, and this is very important point. Observe and follow up your own cases and then think independently. So
My associate, my associate is on the screen. Abida, you want to say something? My associate, Dr. Abida, is on the screen. I wish she says something about the presentation.
So it was a fantabulous presentation. I think you have absolutely sequentially shown everything from the inception of craniovertebral junction, how you've changed the whole concept from a transoral approach, first of all, from a no approach to just seeing it as a radiologic abnormality, to turn it into a very treatable and very life-giving abnormality, not an abnormality now, as you say, nature's protection. And you have absolutely revolutionized the field. And I think rightly you are the father of craniovertebral junction surgery. So thank you very much, and thank you for all that you do.
Thank you very much.
Okay, Juha, you see any questions in the chat?
I think it is very difficult to say more than Abdi was saying. So it is really, really fantastic what you are doing, Atul, and we are very grateful. I can only say that Atul broke the 100,000 audience limit in my webinar. So since September 2020. So now the audience was around 2,500 and certainly will increase during the weekend. So I don't know how many outside of China are following. I hopefully very many, and I hope this lecture will be saved so that many people can see it, because it was very fantastic. So it is also a good model how to lecture, how to make your lecture, make a very convincing lecture so that the people get the message based on large experience.
Well, you know, Juha, I'll put a link in the chat of all the webinars that Dr. Atul has done with us over the last couple of years. It's quite an impressive number. It's a YouTube link. And hey, let me just show you, Juha, before we wrap up, what's going on this week, and it involves China actually. This is today's presentation. Okay, Juha, you're speaking in Latin America, or you're speaking, your audience is based in Mexico. Are you there, Victor? You want to talk about the conference?
Yes, next Tuesday. Yes.
Next Tuesday.
Okay, that's Tuesday, right?
Tuesday, yeah.
Tuesday, 8 a.m. Okay, and also we have a lecture on neuroanatomy and augmented reality with a friend of Juha, Dr. Winkler. Can you say a word about Dr. Winkler, Juha?
Yeah, he is a great neurosurgeon in Salzburg, Vienna, and my good friend, and just retired, and has a great anatomical lab. So now taken care by Ottavio Tomasi.
Yes.
Now I remember the name. So Ottavio Tomasi is treating them. I will be there.
Great. Yeah, he'll talk about. He's turning over the lab to someone else. So, well, thank you very much.
Ottavio Tomasi.
Thank you very much, Juha. Do you have any plans for next week yet? We'll decide.
Professor James Liu will talk next Friday.
Okay, James Liu.
Oh, great. Okay,
Liu.
Very good. Thanks everybody for coming.
Okay.
A great
Thank
session.
you.
Dr. Well, you're the king. You're the king.
Thank you,
Yeah.
You maintain your crown.
Good night. See you tomorrow.
Dr. Atul.
See you next week. Thank you.
Dr. Atul.
Yes,